Hi, I'm Dr. Angeli Akey.
And I'm Dr. Kathleen O'Neil Smith.
Welcome back to the FIRRIMup Doctors, Good Medicine docu-series.
We are so glad you joined us.
We want to provide you with credible health resources, guide you in your treatment options, and fire you up to take control of your health. Hi, I'm Dr. Angeli Akey.
I'm Dr. Kathleen O'Neil Smith.
And we're the FIRRIMup Doctors. We're actually here to talk about something very serious, actually. This COVID-19 coronavirus pandemic.
It's really been something that's hit us by surprise, and something that I think is we are still in the beginning. So the important thing about it right now is to take it seriously.
Yeah, I think, have you had a chance to see Bill Gates' TED Talk on YouTube from 2015?
I heard about it.
Yeah, my son from Oregon, he showed it to me last night. So Bill Gates did an 8-minute TED Talk on how the United States is ill-prepared for a pandemic, and he recorded it in the wake of the Ebola outbreak in Africa. And it was completely prophetic to what's happening now. I think specifically what I recall, the parts that hit home to me were, number one, the lack of an infrastructure to actually respond to anything like this. And number two, the lack of coordination of people, professionals. For example, you have the Army, Navy, Air Force, Marines ready to go, but do we have a core group of physicians ready to go to actually take care of patients that that understand the importance of this? Now, granted, we have the CDC and they have the Epidemiologic Intelligence Service, but do they actually have clinicians ready to go to communities and start setting up what I think will be big tent clinics all around this country? And the answer—
Well, we certainly have them here in Boston. We have big tent clinics presently, but I think it's bigger than that, because you can't prepare for things you don't know, and this is a very novel virus. And I think, certainly the New York Times has written articles a year ago almost about our lack of preparedness. Many people have warned on our lack of preparedness, including Bill Gates. But I think the fundamental thing is we are ready. There are certainly physicians, and we know them, we've had conversations with them even this week, who are prepared to get up to speed. The issue is leadership. We really have a leadership issue, and we should not have a problem with supply chain. So that's not okay. And leadership, and basically getting the information out that is going to be valuable to the people who need it. So there's a lot of misinformation out there. So leadership is really, I think, the biggest issue, because we need somebody who has a strategy in the first quarter, the second quarter, the third quarter, so that we win the fourth quarter here. And the first quarter is done, and we didn't do a good job. We have an opportunity in the second quarter of this game. It's not really a game, but in this epidemic, and we could have learned from other people, and I think we need to learn. And I think we need the scientists to lead, and that's really the issue. If we had leadership, I think people would trust more. And the reality is that everybody needs to realize that we're all in this together. We all will know somebody affected by this. We all will know somebody affected by this. And that's going to be, with what is it, 2,000 or 3,000 deaths in Italy in 3 weeks or 4 weeks?
Yeah.
That's what it's like. And my understanding is this is not just affecting the older population, that 40% of the people in the ICUs needing care in the United States are under 54 years of age. So that's pretty critical. What's your understanding on that, Dr. Akey?
Well, I was I'm actually still stuck on your issue of leadership. I had a comment on, I've been knee deep as a primary care doctor in North Central Florida, trying to take care of my 6,000 patients. And, I tried to follow the protocols, the CDC and the health department, try to refer them to the health department, and they're just frankly understaffed. And so I took matters into our own hands in our own clinic, and we have these drive-up evaluations, but we have very limited COVID swabs. So then I actually posted how to do these drive-up evaluations to protect the sick people. I mean, to protect the well people who come into the building. We separate the sick people to the outside. And so I taped it and sent it around, and it got over 3,000 views in 24 hours. So then I did a Zoom to teach anybody who wants to learn how to do it yesterday at 3 o'clock. And I got a doctor from Albuquerque whose practice is in charge of 1 million lives in Albuquerque, and I got the health department involved. And I was very sad to hear my local county health department has a capacity of seeing 6 total patients a day, which is 1 hour of visits because they have to swab and clean, etc. And they're understaffed and under-resourced, and they don't have protective equipment.
So I think the important thing to note is, this is all good and this sounds very scary. So I think we need to come up with what do we know to be the guidelines presently for who gets tested. So I think that in what we have in Boston, I think probably more and more around the country, is a hotline that manages many of these tents. So you have to call the hotline. And everybody who thinks they have symptoms and are actively expressing a COVID-like infection, they have to go through the hotline. And they have to go through those outer tent structures to be tested. And that's what's going to keep our healthcare personnel safe.
So you're ahead of us, because I think it hit Boston sooner. Just today, our governor announced that they would set up these structures in 2 cities. I think it's Miami and Jacksonville. So we're in our community, we're actually just starting to get that going. So we're behind you guys. But I think the current protocol, at least in our town, is if you're older, over 60, some guidelines say 65, or at high risk because you've been around people with the COVID-19, or if you've traveled to the high risk countries, then you should be tested, but there's like no tests. So
nobody here is testing anybody who has high risk unless they have symptoms. Nobody.
Yeah, so right, with symptoms, high risk with symptoms.
Yeah, right, okay. So here, there are a lot of high risk people that I know who are being turned away. The primary factor for testing is temperature.
Okay.
Along with a respiratory symptom or a pressure on the chest.
So what temperature are you guys going, 100.4?
100.5. 100.5.
And so have you had any patients actually get tested?
I have not. I have patients who are high risk, but they have not been able to be tested. They have been turned away, predominantly because of age.
High risk with symptoms?
High risk with symptoms.
Oh, so they're under 65.
They're under 65. And the primary issue is that there's limited tests. So with limited tests at this time, there's limited availability for testing people that you think may or may not need hospital-based care.
Right, exactly.
Mm-hmm.
And I also heard that in Colorado that they quit testing. Yes, that they just assume that you have the virus. I need to verify that, but I heard it from a physician. So,
well, I think that makes sense right now, because I think that we all have to act as if we have the virus, whether we're demonstrating symptoms or not. If everybody assumes that this is a ping pong ball that's, bouncing around, the goal is to stop the ping pong ball. The problem is we can't see it.
Right.
We cannot see this ping pong ball as it bounces. If we could see it, we could stop it, but we don't have adequate testing, so we're not going to see it presently, and there's no catch up. We're getting to halftime here in the game, in the end of the second quarter, and we're not going to catch up with that. So I think the reality is if we all behave as if we have it, and we could transmit it to a loved one who was at risk for needing a bed that wasn't available, I think that's really, really important. So I think if you have symptoms and you have the pressure on the chest and you have a fever and you are high risk, you should absolutely try to find a way to be tested.
Yeah, I think hopefully it's going to be more more prevalent to these testing centers in Florida. I'm just curious though, like, let's say one of your patients has a fever and they get told to go to the testing centers. Are your testing centers, do they have airflow and protective equipment for the doctors?
Yes.
So that's what we need in Florida. We're just behind you guys, but I
Mhm.
think it hit Boston harder and sooner than it hit in Florida.
Well, because of the Biogen conference where everybody came out positive, 75 people were positive in one day.
Wow.
In the scientific community. So thank goodness for that. So we do, the partner system, which is Mass General, Brigham, and outerlying hospitals, everybody has tent areas set up. They have protective equipment available. I do know that not here necessarily, but they're asking the healthcare professionals to use them over and over again. Their masks, their equipment. I do not think that we're in a great situation, and I don't expect Florida to be in a great situation, because I do think that there are limited supplies of everything that we need. And that's why it may be wise, like Colorado, to say, we're not going to test because we don't know who to test, and you have to behave as if you have it. And I think that's the best advice that you can give somebody, is I think most importantly, if you're asymptomatic, behave as if you have it. And we talked about this on our class with the doctors the other night about the STDs.
Yeah, I love that analogy. It was fantastic.
Yeah, if you have an STD and you don't have symptoms, but you give it to somebody, you should behave as if you have it and use condoms. But right now we don't have condoms available. So pretend that you have it, and that means no sex, right? So until you have protective equipment. So right now, we all have to behave as if we can transmit a disease similar to STDs to somebody that we love, and that it would be fatal, that it could be fatal, that it would cause a significant problem. And we have to wash our hands, and we have to do our very best at, really being conscious, being mindful of the behaviors we have each and every day that we do, because this is out of our realm of our mindfulness. This is beyond mindfulness, because there are many things that we do that we're not thinking about. And one of the questions I thought was really pertinent, I had heard this before it was talked about on the news, and it was one of my Italian friends from Italy was telling me that her family were washing their shoes because they think it was transmitted on shoes. And shoes are what we call fomites as well, just like a countertop or anything. They're going all over. They can be stepping on droplets. They can be carrying this virus. It's not like they're just carrying it for no good reason, but if you're in a vicinity of droplets that are being deposited and you carry that for a short time, they can be a mode of transmission. So it's more tricky than we realize. And I think that that's the main reason that I do think that we have to behave as if we have it.
That's a good point about the shoes, because even within my own family, they still walk in our house with their shoes on. But what if someone spit on the street? And we know that some estimates with the mucus are 3 hours of contagion up to like days, right? So we need to take, the Asians, we all take our shoes off before entering the house. I think we all should consider taking our shoes off.
Right. I have a lot of friends here who are washing their they're washing their shoes every time. If they go out to a supermarket or a pharmacy or things like that, they're washing their shoes. And look at that, I just touched my face. I mean,
there you go.
Don't even realize, right, that you're touching your face. It's hard. You have an itch, you scratch, you don't realize you're taking your shoes off, you're touching your face. There's so many components to this. That's why even quarantining is helpful, because remembering everything that we're doing and being aware of each of our moves is pretty challenging.
Yeah, I was taping the information on how to do these drive-up evaluations, and I actually had touched my protective equipment. So one of my colleagues in Pennsylvania emailed me, was like, you totally violated, you touched your mask. I'm like, I've had no formal training since medical school on how to use protective personal equipment, but it's all an educational process that we all are having, like, to be really agile and to learn quickly, and all these habits to steer the ship.
Yeah. What are you understanding in terms of the time frame from your perspective?
So, you get infected. This is from the information that I was listening to some webinars from Johns Hopkins. So basically, you get infected, at time zero. And then a lot of people start having cold symptoms shortly thereafter, but the peak viral shedding is day 6 through 9. And unfortunately, that's when they're sicker and they encounter us as healthcare professionals and are contagious, very contagious to us. Then you see us and we don't have, most of us don't have, they're not blessed like me to have a hazmat suit with a mask respirator. So you hit the ER and they literally down the street, my ER doctor friends have just the standard mask because the N95 masks are out. And so they're starting to get sick. In fact, today I saw a nurse from a hospital, not in my town. She came from another town in North Florida, who a circulating nurse came down in the OR, had come down with positive testing for COVID-19, and another person in the hospital came down with it too. So this was a nurse who was working with those two nurses who came down with this. Her history was she's a 28-year-old nurse who 5 days ago developed this, like, she felt like a Mack truck had hit her, just myalgias where she would just, she felt like lying down.
Yeah.
And chills. And then she developed, 3 days ago, she developed sore throat. And she got worse and worse till till yesterday, she called to make an appointment to see us. And actually today, because she's young, she actually just had myalgias and sore throat. So I was able to do a rapid strep, influenza A and B, even though she had the flu shot. She's a nurse in the hospital, and the COVID, but she actually, I think, will test positive. So yeah, I
it's
think
hard to know. I think the pains are really one of the symptoms, the myalgias and the diffuse pain, as well as a heaviness on the chest.
yes.
And cough. It's not real mucusy that I understand. How about you?
No, I haven't seen a lot of phlegm with the ones I think that are COVID. Now I sent 6 out to Quest and I'm still pending those results from this week. So, but I do say a lot of my drive-up evaluations actually, I think, end up being sinusitis, or if you look at outside of Florida, it's bloom season and there's a ton of pollen in the air. So I think I'm seeing a lot of people outside who have seasonal allergies. But when you take histories like this, where they had definite contact with COVID positive people and they're acting like they're otherwise healthy, and all of a sudden they're brought to their knees, that's either the influenza virus, right? Or it's the COVID, I think.
Where did the COVID positive people get tested? How do they know they're COVID positive? The people that they were exposed to?
Because the patient who had come in for an operation ended up having COVID. So then they tested the people who had interacted with that patient.
I see. Mm-hmm. Yeah.
Yes. So, but my patient who I saw today had requested COVID testing and was denied, which is why she called us. And I went ahead and tested her.
Well,
and
certainly.
I put her on quarantine for 14 days.
Did she have a fever? Curious.
She's been having fevers to 100. It's lower than 10. It's 100.4 to 100.7. And she's a nurse, so she was monitoring her O2 sat and her temp. Her sats have been in the mid to high 90s. So she's actually going to recover just fine. I'm a little disappointed at her institution for not testing her and not telling her to stay home.
Right.
Yeah, I benched her. I said, you're benched, you just stay out for 2 weeks. So we'll see what happens. I should have the result in 4 days.
I think what they did at the Biogen conference, I live near to some people who work at Biogen, they did not test them. They said, act as if, go home and quarantine yourself for 14 days. And I know these people well, and they quarantined. They sent me email, we're here, we're quarantined. We never had a test, but we're acting as if. It's been 14 days now for them, I believe. It's Thursday, I believe it's 14 days. And they have not become symptomatic. But they're still not going back to work.
Yeah, but do we understand the natural history? If you actually get quarantined because you were exposed to COVID, or you might actually have COVID, does it mean that you're fine? Or if you get stressed and immunosuppressed, it's going to mount itself? Do you have a carrier state? We don't know, right? We don't know.
I think the one thing that we do know is steroids are not good for this.
Steroids and non-steroidals as well.
Exactly. So anything in that category is, if you're on a steroid for one reason or another, you've got to be super duper cautious. So I know, and non-steroidals as well. So I think that those are two very interesting things. But the woman who works at Biogen, there's a man and a woman. The woman who works at Biogen is young, in her early 50s. She actually had a stroke for unknown etiology, maybe a year and a half ago. And I don't know what medication she's on. She's not a patient, she's a friend, but they have been very strict about it, and they're working from home until further notice. I mean, everybody is really, pretty much the goal here is to be sheltered in. You don't see many people out.
Well, you're getting back to your friend though, even though she's under 65, because she's had a stroke, she's actually at high risk for the virus.
Mm-hmm. Yeah, but she didn't develop fever. So they, just said, act as if you've had it, go home, quarantine. She was very obligatory and is doing her due diligence, does not want to expose anybody, and has not really left her house.
How did they know the over 70 people contracted the virus from the conference? Is it because they got symptomatic and were tested?
You mean the 75 people?
Yeah, 75 people at Biogen?
Yeah. They were symptomatic.
Oh, okay. Mm-hmm. Were there any deaths from that?
Not that I know of yet. I mean, I noticed on the news from last night, 11 p.m., it was 4,700 cases in the U.S. Today is almost 12,000. Yeah,
so I guess they're testing more. I'm actually on the Johns Hopkins website from the from the engineering department. So I have those real numbers. So you had asked how many deaths in Italy. It's 3,405 deaths.
Right, in a short time. So it's not, that sounds like a low number, but this is in a matter of weeks.
Yeah, and I heard that some of that was also because they have a lot of seniors in the culture. In Italy, or multi-generational families hang out, and so you have the asymptomatic youth hanging out with grandma who has COPD, and next thing you know, she gets it and can't have the resiliency, and she dies. Right?
So, absolutely. So what are you telling your patients? What's happening in your 6,000 patient PCP practice? I have, a 1,500 patient practice that's very different. It's subspecialty, so I'm doing all telemedicine, and there's nothing that we're doing urgently. Of course, the patients I have illnesses and medical histories. They don't come for no reason, but and some of them are at risk. Nonetheless, what's happening for primary care?
I'm actually trying to lead the charge in my county to encourage the private doctors like myself to segregate the sick from the well. And so at least they're doing it within their own buildings because they don't have testing capability. So that's number one. Right. Number two is the mold remediation company came to do viral mitigation in my office yesterday, and we'll have them come weekly. So we're sending a email out to all of our patients via constant contact that we're really segregating sick from well. So if you're under 65 and well, don't be fearful to come in. We're doing primary screening on the phone to make sure that the appointments are only well people are coming in for the in-house appointments. Otherwise, they're going to come in for these dues visit outside in the parking lot. And then we have a screener at the door. So we have two screenings set up to really make sure. So if you come in to review your labs and we screen you out that you're sick or you have any respiratory symptoms, you get converted to an outside visit, which people stay in the car. And actually, you guys could look at our face. If anyone listening to this wants to look at the videos, it's at North Florida Integrative Medicine Facebook page, all these videos on how to do it. And if you email me, we'll send you the exact how to do it because we have a PowerPoint on it as well.
Dr. Akey, though, the question I would have on that, and I'm not really an alarmist, but I wonder, again, if this is a ping pong ball bouncing around and we can't see it, how do we know if those people are well and aren't transmitting the virus?
So just before we came on together, I was actually reviewing all the telemedicine. I was on a telemedicine webinar, and basically we're trying to convert everybody over to telemedicine. So right. The federal government has responded by saying they're relaxing HIPAA guidelines for 90 days. And I just found out today that all insurers, verified for your own state, that's what I have to do, but all insurers are going to allow telemedicine visits, even in insurance-based practice. So
So basically you're saying telemedicine was not available before, right?
it
Right
wasn't.
now.
And actually last week, only standard red, white, and blue Medicare was approved for telemedicine, but now everything's been changed. And so, so we're trying to move online. And even in my outside visits, I actually don't approach everybody. I only approach them if I need to examine them. So in my, let's see, on Monday I saw 7, Tuesday I saw 12, Wednesday I saw 12, and today I saw 6. But I didn't touch everybody. I call them on the phone, and we're allowed to bill by time, right? So I do an interview, but the few I saw, like I think today I actually approached the car, and actually 5 of the 6, because I had to differentiate what it was. And actually one had sinusitis, one I think had pneumonia, 2 I think actually had COVID, and they were in the same car together. So, I try not to approach people, but I did get the specimens and everything else. So, yeah.
So you started the testing now 4 days ago. How long does it take for it to come back?
4 days. Now, I was promised by a specific company to have reverse transcriptase PCR swabs on Tuesday, but then they got swamped and I still have yet to see them. But with this specific company, the turnaround time was going to be max 48 hours. So I'm not sure, that probably went to higher priority areas, I guess. But yeah, they're hard to come by, these swabs.
Well, what about the results though? Well, how do people get their results?
Oh, I'm going to get them in 4 days. So I should have my
From Monday, you should have some today.
Yeah. Yes, by Monday I should have some. Yes, and I'll be.
And do you have any of the patients on Monday who converted and now continue to have high fevers or any difficulty breathing 4 days ago? So if the window is a certain window of time where they may become more and more symptomatic, what's happening?
Exactly. So I just got a text saying somebody I saw earlier this week is getting worse. Can I see her tomorrow again as that type of visit? So it might be something that's in evolution. Right. I'll know as I treat more and more of these patients. But again, I'll be out of swabs after these next 2, and I've requested several from several sources. So,
but you wouldn't do another swab on the patient because you've already done it. So let's say the swab is positive. Then what happens if she's continuing to get sick tomorrow?
Yeah, so that's great. Let's talk about therapy. Are we talking about monitoring and management versus innovative progressive therapeutics, or what are we talking about?
Well, what are you realistically going to do?
Okay.
What are you realistically going to do tomorrow? If this woman shows up and she's worse, and she can't breathe, what happens if she was positive? If she was negative, because you should have her test result back, then what do you do? We have 2 scenarios.
Yeah, exactly. So
but she's unwell. We're just going to say she's unwell.
Okay. So you do, I have to decide if I need to assess her, right? And I actually recommend everyone go on Amazon and buy their own pulse oximeter. Because I think if she's hypoxic and we didn't screen that out because she was talking fine on the phone, then obviously I'll have to call my neighboring ER and send them there. But I think you bring up a good point, which we have on our standard operating procedures. If she has chest pain, if she's turning blue or anything like that, call 911, go to the ER. But I think the role of the primary care professional is to screen out the stuff that doesn't need to go to the ER. So I actually will get off the phone, get off the call with you and call her. And if she's that bad, getting worse, I'm just going to give my ER a call and say, heads up, I'm sending you a potential COVID patient. Now, it happened yesterday that I had a 42-year-old woman who's.
Wait, can we stay on this patient?
Yeah.
Can you call today and get the result of her COVID test so they don't use another test on her?
It's too new to know, actually. So basically it would be 3 days old, right? So I would call and see, and probably not, we'll see. But if I did, let's say she's COVID positive, okay, and she's telling me she's unwell, she's getting worse. Then I have to do my clinical assessment on the phone, whether or not to send her to the ER at this point or not. And if not, I would see her tomorrow and assess her, or I might not. I might just call her. And the lady this morning, for example, I just looked at her from across the parking lot, and I knew her that well from 20 years of managing her COPD that I didn't feel the need to expose myself to her. I knew exactly what was going on.
So you did what? What did you do?
This morning?
With the patient this morning, you sent her to COPD, or you sent her to the lung disease patient?
Yeah,
You
so
sent her to the ER or what?
no. I've managed her COPD for 20 years, and she's got just mild.
So she has COPD, not COVID.
Right.
And how do you know? Did you do a COVID test? What if she has COPD and COVID?
And she's really, really sick, and she should look really, really sick, but I am monitoring her. She's been sequestered since this started, intentionally. Like, I had seen her and I said, this is coming down. You have to become a hermit, because I've managed her COPD for 20 years. So she basically said that she felt like she was getting the phlegm again, and she was getting worse. And I said, you might have COVID. Where have you been? And she said she's really been sequestering herself. So I actually didn't use one of my swabs on her, because I don't have many swabs. She actually looked too good, because I've seen her much worse. And I said, this gets worse. Okay, if you can start getting worse, you need to let me know, because you're right. If she's in the early phase of COVID, she could be getting worse, and then she'll peak out day 6 through 9, is what I understand. And then she could potentially go downhill fast.
And she's a high risk patient because she has COPD, right? Yeah.
And she's on Medicare. She's over 65.
And does she have the temperature? I mean, we also need to be something so basic like following.
Yes. So within my protocols, they're actually asked to check their temperature before they come in. And so she hadn't had a temperature at home. So basically, when I need information, and I recommend every doctor do this, is a lot of people have thermometers at home. They have pulse ox, they have automatic blood pressure. So I want to know that data with this when they call me, because we're getting a lot
So I had a patient today who had a temperature of 109. I said, honey, if you have a temperature of 109, you'd feel it. You wouldn't need to take it. So the thermometer's not right, I'm sure. Do you feel like you have a temperature? He wasn't sure. So I think we have to, the numbers are good, but we need to kind of look at the patterns of the fever, right? And just see what are those patterns demonstrating. If they are 99, you can check an hour or two later and see what the patterns are showing. But I'm sure he didn't have 109, because he would have been delirious and not calling me. He lives alone, and he's an EDS, Ehlers-Danlos patient, and very worried, and has had a lot of illness.
So with EDS, remember they have leaky gut. He's probably an autoimmune patient, right? So he's at high risk.
He's at very high risk. He's been sheltered in, so in quarantine. He lives alone. He's having things delivered. He's very frightened, so he'll stay in. He's young. He's in his 20s, but he is a high risk patient. He did call to see if he could get tested at the Mass General in the central system, and they said no, not yet. He'd have to be sicker to get tested.
Does he have autoimmune disease as well? Yeah, because they pretty much all do. A lot of POTS syndrome, postural orthostatic tachycardia syndrome with EDS, and now I've finally put it together that it's their leaky gut from their messed up collagen. So.
Well, it's really important that he continue to, I think, stay alert to how he's feeling in terms of his fever, and particularly the fever. Because if you have a fever that's going up, you can often tell. So he has to stay in tune to that, I think, more than anything. But and if he does feel short of breath, I think he just calls 911.
But in general, in terms of the Boston infrastructure, so you have these tents outside. Is that where people are landing? They're not going to the emergency room anymore?
No one's allowed to go to the emergency room. Everything's locked down. You don't get to walk into an emergency room. No.
Wow, that's what we need. They're still walking into our urgent care and emergency rooms, and it's just spreading all around. So
yeah, nobody gets to walk into an emergency room here.
So whether or not you have a sprained ankle or a respiratory symptom, you're going into a tent.
If you go to the emergency room, yes, you're going into a tent to be screened. I mean, everything is shut down for non-emergent visits and things like that. I mean, most of it's telemedicine at this point.
Wow. So is Boston shut down? No restaurants, no bars, no
restaurants, no cafes, no bars. Everything is closed except for supermarkets and pharmacies. That's it.
But the doctor's offices are still open? The private doctors?
I don't think they're still open. I'm not open. You can't come to my office. I can speak with you, but you're not coming to my office for anything. And this young man asked also about going to get labs drawn for some treatments we're doing. And I said, look, that's not urgent. There's no lab work that's going to be done. So really, unless it's an emergency, one of the concerns I have here is that ironically, I mean, they've shut down aesthetic studios and everything,
Yes.
MDs who do that, but they haven't shut down dental offices.
Really?
I don't even understand that whatsoever. I think that is the most absurd, in particular orthodontists, which I just think,
Wow.
what are we doing putting our hands in people's mouths, regardless of who we are? So I think, again, this comes back to the preparation, the preparedness for these kinds of things. Even though we heard that this was bad, we still didn't think it would happen to us.
Right.
Because many of these people are just like, well, life as usual until it hits me, which I think is really, we need leadership for that, because that's a big issue. And then the second thing is, not only is it life as usual, but then from the other perspective, there are people who are thinking, well, I have to pay my bills, so I'm going to keep going as long as I can. And that's another issue. So there's a vision around, we're giving mixed messages. Even the clinicians and the dentists and whoever are giving very mixed messages. And I think we need to clarify those messages. And the messages are, act as if you have it. Because if you do, you will save a loved one from potentially a hospital admission, and worst case scenario, from a death. And somebody that if we do have, in the literature I read from some physicians who do kind of statistics in Europe, they were estimating 2 million deaths, and
in the United States?
In the United States, 2 million deaths.
Wow.
Best case scenario would be 1 million if we acted as if we had it.
I heard a statistic from the 1918 swine flu, I believe, was 3.3 million deaths. And so, but that was worldwide, I believe. So this is real. So just 2 million within the United States. I think we're just cresting. We're on our way, and I think we should take note of what happened in Europe, essentially shut down. And wow, I think at least for now, the immediate future, in terms of the call I was having just before this call with Senator Perry's office, our Florida senator for our region, to try to get a center for testing in Gainesville. There was a psychiatrist who's in charge of our university's response for the mental health. And he was simply saying to the senator's office that, so the patients are calling the health department as they're told, but they're saying there's no capacity, so call your primary care physician. So that's the frustration, is that you're hearing these mixed messages. So I'm getting back to your idea of we need leadership, and that's the reason why I had this meeting with our Senator Keith Perry's office today to try to get things happening. What do you mean in terms of leadership? Because what I was thinking was I need some leadership from the state.
Locally, and then, branching out from there. Because if we have leadership in one state, and I think in New York, they're handling this, and we shut down all of the package stores on St. Patrick's Day in New York. People are just going to drive over to New Jersey to get their liquor and come back. So there needs to be a coordinated leadership.
Yes.
Right.
And this is something we've never seen before. I was talking to the Cabbage Patch Kids, the interns, and I said, listen, this is your 9/11. And we're going to be referring to prior to March 1st as the pre-COVID era. And you're in the middle of this COVID storm or the COVID pandemic. And everything has changed.
Yeah, everything has changed.
Not only in medicine, but everything has changed.
Everything has changed. It's really important to take it seriously. I can't emphasize that enough. I mean, I don't normally feel frightened, but this is an unknown. So there can be some, just distress around or stress around feeling the unknown, but just staying steady and keeping everything simple and not exposing other people is what we can do. There's no reason to run out to a store now and get vitamin C, because it's gone. Here in Boston, there hasn't been vitamin C for over a week. There's no zinc anywhere. So, and I think the interesting thing on the treatments, let's talk about that, what they're coming up with. I've seen many, many different things on treatments. And I think for people who are potentially in the ICU, there may be a variety of treatments that may be available, like the chloroquine, etc. The antiretrovirals. I think that's going to have to be determined on a case-by-case basis, big picture, looking at other past medical history for that person. What is likely going on for them, and why are they not able to dampen this cytokine storm or this fire that's being produced in their body from the bugs. So I don't think that there's a one-size-fits-all to that, but I do think that there are some promising medications that are available. Some of the autoimmune medications like chloroquine and some of the monoclonal antibodies and the antiretrovirals, and there are some other IV therapies that may be helpful as well. I think we need to just take that on a case-by-case basis, see what we have available, and do trial and error to see what will help patients. But I don't think there's going to be a one-size-fits-all. Let me give everybody a drug. I received a text 5 minutes ago from a friend who you know, and she said, "Do you have chloroquine available?" I started laughing because remember on our call the other night, one of our physicians tried to get chloroquine.
Yes.
And said it was limited. So I do think that we have to, again, have leadership in that role so that these resources are not hoarded in places where they can't be accessed for the people who need them.
Kind of like the COVID swabs, right? They're rationing the COVID swabs until we can get more. Right. I think that the other countries have tried the antiretrovirals. I haven't heard of China or anybody else using the monoclonal antibodies, but
that's Italy. Italy is.
Italy. Okay. Have they published any outcomes yet, or they haven't pulled the data yet?
Oh, I haven't seen any. But they have positive outcomes.
Okay.
They have people getting off of respirators.
Okay.
And with the monoclonal antibody, and but I mean, they're not going to publish outcomes on one case at this point. But they are sharing that information certainly readily, and yeah. I mean, I think who knows what's going to work. Right. I know that every scientist, I have a patient who, is in philanthropy and has given money to the Weizmann Institute, that they haven't had their peak or anything over in Israel, but they're working aggressively on coming up with testing modalities that are easy, quick, vaccines and other things. Everybody shifted their focus within research to focus on this, to try to understand the nature of this particular virus and how an animal virus behaves in a human.
And whether or not it's mutating, right?
Right. My understanding, we talked about this the other day, you and I, about the mutating. I looked that up and I don't think that anybody has a sense that this is mutating yet at this point.
I'm just curious why we're now seeing younger people getting intubated.
I think we are.
Report? I mean, what happened?
I think that, people have underlying things that they're not aware of, potential autoimmunity, if nothing else. And they could be exposed to, I saw the pictures of people at beaches and bars in Boston on St. Patrick's Day. You could have a high exposure that could overwhelm the immune system's ability to respond. And that's really, really important. Yeah,
and we learned from Dr. Schoenfeld that up to 1 in 5 people have an underlying autoimmunity type condition, right? So it's
already existing in their body, right? Exactly. So I think this is just a really, really tricky time.
Yeah, and I think it's really interesting that you and I have worked on immune systems now for a year together, and we both have independently studied the immune system, and that our book's coming out next month on fine-tuning the immune system. So I'm really excited about sharing that information. So
right, exactly. So fine-tuning the immune system will be a way for you, when you're well, to investigate how is my immune system, and if you've got any particular type of symptoms, particularly anything related to the GI tract, you may want to dig a little bit deeper and understand what is the etiology or the cause, or what's at the base of that problem, so that we can get to the root cause and begin to treat that. And I think, it is absolutely true. We didn't know the value of doing that work and really exploring, multiple studies with respect to immunity and prevention of autoimmunity and autoinflammation and bug protection against bugs, etc., because we know that they're very involved with disease causation.
Who would have ever predicted this world? I mean, just 1 year ago to date, we were in Florence, Italy together presenting at the CORA conference, the Controversies on Rheumatology and Autoimmunity with Dr. Yehuda Schoenfeld. And look at the world now, 12 months later.
It's unbelievable. So I do encourage everybody to stay tuned for Fine Tune Your Immunity, because it's going to be very, very helpful for assessing what's your state of, how good are you? How ready are you to play this game, and get to the finish line without much difficulty?
Yeah, and I think check out our website, because we're posting quite a bit. FIRRIMupDoctors.com. That's FIRRIM up doctors.com. We're posting quite a bit with links to even to our individual practices as well. And maybe next week, Dr. Kathleen, we could talk about how individuals can fortify their own immune system, specifically certain kinds of supplements and progressive therapies.
Sure. Yeah, sure. I think just, again, act as if you have this disease, act as if you're carrying it, act as if you want to be well. And if you don't want to be unwell, make the time to be well and do the right things.
That's my favorite quote you say. That'll do it for now from Dr. Angeli Akey
and Dr. Kathleen O'Neil Smith.
Be well, be safe, and God bless you.
We're so glad you joined us today.
We hope we've given you the tools to take control of your health.
For more good medicine and information about any treatments, supplements, and resources discussed today, please visit us at www.FIRRIMupDoctors.com. That's FIRRIM updoctors.com.
And wherever you're listening from, remember to like us on Facebook and subscribe to our YouTube and podcast channels so you don't miss out. The information provided is not a substitute for professional medical advice. This should not be used to diagnose, treat, or manage health problems without consultation. If you do experience any of the symptoms discussed today, please contact your nearest healthcare professional.